This is going to be Understanding EKGs, Chapter 2. And the objectives on this chapter are going to be describe the sequence of blood flow through the heart, describe the cardiac cycle, including the definition of the cardiac cycle, systole and diastole, discuss the term stroke volume, discuss cardiac output, preload, Starling's law, and afterload, describe the autonomic nervous system. Blood flow through the heart. First component, blood flow through the right heart. Unoxygenated blood flows from inferior and superior vena cava into the right atrium through the tricuspid valve, into the right ventricle, and through the pulmonic valve. So the venous side and the blood return flows from the superior and inferior vena cava into the right atrium, and then from the right atrium it flows into the right ventricle, and then from the right ventricle, whenever the ventricles contract, it flows into the lungs, which are here. Second component, blood flow through the pulmonary circulation continues when the blood travels from the pulmonary arteries into the lungs through the pulmonary alveolar capillary network and into the pulmonary veins. On the lung side of it, whenever we're here and here, lung, blood flow coming in, right atrium, atria contracts it into the ventricles start to contract, the blood flow goes into the pulmonary trunk. Whenever it enters there, whenever it enters into the pulmonary trunk, it crosses across small areas of capillary alveolar sacs. Now these are loaded with tons of capillaries that are running across them. As the blood comes into these capillaries, the CO2 is transferred over into the alveolar sac and expelled out the trachea, out the lungs, out the trachea, out the opening in the mouth and nares. And then the oxygenated blood that's there, or the oxygen that is in the alveolar sac, transfers its oxygen to the red blood cells simultaneously. And you ventilate 20 times a minute, so this movement of air in and out of your lungs is what oxygenates the blood that's coming through there in the alveolar sac and in the pulmonary trunk. The cardiac cycle represents the actual time sequence between ventricular contraction and ventricular relaxation. So the cardiac cycle itself, whenever we talk about a whole cardiac cycle, it'll be from the contraction that occurs in the ventricles to their relaxation, and most of the passive filling occurs during relaxation. So we're going to see a lot of things occurring during diastole, or blood moving into these chambers. Systole is the simultaneous contraction of the ventricles. So whenever we say systole or systolic blood pressure, this would be the highest amount of pressure in the blood pressure due to ventricular contraction occurring. Diastole is synonymous with ventricular relaxation. The ventricles fill with 70% of their blood passively from the atria. So during the relaxation phase, everything is kind of open and the blood is just flowing into the ventricles. It isn't until we get the atrial kick that it superfills or stretches the ventricles so that the ventricles can have the cardiac output that we recognize that they do. During periods of ventricular relaxation, cardiac filling and the coronary perfusion occurs passively. One cardiac cycle happens about every 0.8 seconds. Systole lasts about 0.2 seconds. Diastole lasts about 0.52 seconds. So diastole lasts at least twice the amount than systole does, and that allows for passive filling to occur. And like I said, we get about 70% of our cardiac output from the passive filling of the ventricles. Now, we're going to look at this in multiple phases here, and I'm probably going to have to clear the board from this digital pen. So we're going to start here with late or early and late ventricular diastole. So this is the relaxation that is occurring. Now, in late ventricular diastole, do you see how it's flowing into the atria and then also flowing into the ventricles? Same way, this over here is coming from the pulmonary trunk and is oxygenated, and this is flowing in and then flowing into the ventricles. Now, all this is occurring whenever the ventricles are relaxed or in diastole. It isn't until the atria contract and superfill or stretch the ventricles. Now, how this occurs is this is where these AV valves come into place, right here and here. At the point that the ventricles are stretched and they start to contract themselves, it collapses these AV valves and pressure builds up in both left and right ventricle. As the pressure builds up, it opens up or pops open the semilunar valves, which are either going to the pulmonary trunk to be oxygenated or going to the body to provide oxygen to the tissues. So again, atrial systole, we'll start with A. Atrial systole occurs superfilling the ventricles. This is Frank Starling's law, which we'll talk about here in just a few, in direct relationship to cardiac output. Superfills the ventricles start to contract, it pops open, the pulmonary semilunar valve and the aortic semilunar valve, and either pumps it into the lungs to be oxygenated or pumps it out to the body to provide oxygen to the tissues. Relationship of blood flow to the cardiac contraction. Okay, again, this is the diastolic phase side and this is the systolic phase side. So during diastole, if we'll notice, the pulmonary semilunar valve, which is here, is closed, and the aortic, which if we follow through here, semilunar valve is closed as well. Passive filling is occurring. Blood is flowing into the atria, into the ventricles. At the point that the ventricles start to contract, or they go through their systolic phase, these tricuspid and bicuspid valves, or the AV valves, here and here, close due to increasing pressure, and the pressure increases enough to where it pops open the pulmonary aortic valve and the aortic valve, aortic semilunar valve and the pulmonic semilunar valve. So during systole, when contraction occurs, you're either providing deoxygenated blood to the lungs or oxygenated blood to the body. During the diastolic phase, at the end of it, everything's kind of open and allowing for blood to flow into the ventricles. It isn't until after that that the atrial kick occurs, or the atrias contract and superfill the ventricles. There's where we get the rest of the, or 30% addition to our cardiac output. Quick overview again. 70% of our cardiac output comes from passive filling during the diastolic phase. It isn't until the atria contract that we get our rest of our 30% of cardiac output. This superfills the ventricles so that they can interact and stretch just a little bit. This allows the ventricular muscles to provide more cardiac output. Stroke volume. Stroke volume of the blood pumped out of one ventricle of the heart in a single beat or contraction. They estimated this is approximately 70 milliliters per beat. Heart rate, the number of contraction beats per minute. Normal heart rate, or intrinsic rate of the sinoatrial node, which we'll learn in further chapters, is 60 to 100 beats per minute. Normal heart rate, 60 to 100 beats per minute. Cardiac output, the amount of blood pumped by the left ventricle in 1 minute. The formula to determine the cardiac output is the cardiac output equals the stroke volume times the heart rate. Now in this stroke volume, the stroke volume actually has more parts to it. Stroke volume itself would also be determined by how much blood is entering into the actual heart muscle itself, and the amount of peripheral vascular resistance or the amount of vascular constriction that's occurring. The heart rate and all of these equations pumped into the stroke volume is what both together equal cardiac output. Cardiac output varies from person to person. Inadequate cardiac output may be caused by congestive heart failure, myocardial infarction, or shock. And whenever we talk about cardiac output, there's three things that really mess up cardiac output that we can always have problems with, or hyperperfusion states. One of them is if the pump fails. The next one is if the vessels or the container is too large. And last but not least, if we don't have adequate amount of fluid, that will become problematic as well. So there's three things that we can adjust and fix, and there's also three things that cause all the types of shock that we'll see. It is either a pump, a container, or a fluid problem. Cardiac output may see combinations of symptoms: shortness of breath, dizziness, chest pain, decreased blood pressure, cool clammy skin. The shortness of breath, the body realizes that it's going into a state of hypoperfusion, so it will increase respirations with this. The patient may feel air hunger and air starved. Dizziness may occur if there is a loss in blood pressure or a near syncopal episode. Chest pain may occur because of inadequate perfusion of the coronary arteries. Decreased blood pressure is hypotension. It's a late sign of shock. Cool clammy skin is generally pretty early. At the first glimpse of decreased perfusion to major organs and organ systems, the body will generally shunt blood towards the core. It does this by shutting the precapillary sphincter, releasing sweat from sebaceous glands on the surface of the skin. This does two things. It makes the patient's skin very pale, and it also makes them a little clammy whenever you feel them to touch. If this is allowed to process for a while, it allows the skin to cool down. This assists further in the constriction of the vessels, which makes their skin cool and clammy. Preload, or end-diastolic pressure. Pressure in the ventricles at the end of diastole, this would be at the end of the relaxation phase, directly affected by the volume of blood that returns to the right atrium. This is also why whenever we give somebody a fluid bolus, that we do it in the venous side. The preload pressure is the amount of fluid that enters into the heart on the right side. So the preload amount is directly relational to the amount of fluid that I have returning to the heart. This is also why whenever we give a fluid bolus, we pump it in on the venous side. An increased preload then would provide a greater cardiac output. Afterload pressure, resistance against which the heart must pump, affects stroke volume and cardiac output. If the vessels are too large from a distributive type of shock, the heart itself will be throwing blood into a very floppy system. If they're too constricted down, or there's too much afterload pressure or too much blood pressure, the heart may not be able to perfuse well enough due to an increased afterload pressure, or what it has to pump against to open up the semilunar valves. Frank Starling's law of the heart. The first concept is a law of physiology which states that the more the myocardial fibers are stretched to a certain point, the more forceful the subsequent contraction will be. This is also called the rubber band theory. The farther you stretch a rubber band, the harder it snaps back to its original size. This is where the atrial kick comes into play. As the ventricles passively fill, 70% of our cardiac output is done by the amount of preload that is coming into the heart and its passive filling. It isn't until the atria contract that we get this other 30%, and it stretches the ventricles. That stretching of the ventricles allows for 30% more cardiac output. And this is a direct example of Frank-Starling's law. Peripheral vascular resistance. Peripheral vascular resistance means the size of the vessels. Peripheral vascular resistance, the amount of opposition to blood flow offered by the arterioles, determined by vasoconstriction and vasodilation. Blood pressure equals cardiac output times peripheral vascular resistance. Now, if we'll remember, cardiac output meant stroke volume times heart rate. So, stroke volume times heart rate times the peripheral vascular resistance, or pretty much the size of the vessels, is what's going to equal our blood pressure. Autonomic nervous system. The autonomic nervous system regulates functions of the body that are involuntary or not under conscious control. It's not like you can stop your heart by a thought process. Heart rate and blood pressure are regulated by this component of the nervous system. This is for everything that we would be doing that we don't have mental faculties on. Examples of this are going to be peristaltic movement of your small intestines, dilation of the arterioles in your kidneys, the actual size of your vessels whenever you're standing. You don't have conscious thought over those examples. Those are all run by the autonomic nervous system. So whenever you hear the autonomic nervous system, if you'll think automatic, it automatically runs functions that you do not have conscious thought over. Two major subdivisions of the autonomic nervous system are the sympathetic nervous system, which is pretty much fight or flight. Examples of this is if you saw a pit bull, pardon, if you saw a pit bull or you saw a T-Rex, that your body would go into a fight or flight mode. You would either have the ability to fight the T-Rex or pit bull, or the ability to run away from the T-Rex or pit bull. And the parasympathetic nervous system, which is the opposing nervous system to the sympathetic, regulates the calmer function of our resistance. This is the rest and digest. So if you go out to Amarillo and you eat the 80-ounce steak, the parasympathetic nervous system would be the one calming and digesting this big large hunk of steak that is in your intestines. Nervous system control is controlled both by the sympathetic and the parasympathetic. These things work like a teeter-totter. If one becomes dominant, the other one will eventually increase its tone to compensate for the other side, and vice versa. There are lots of areas that the parasympathetic nervous system and the sympathetic nervous system control. A couple examples here as we're looking at this. Sympathetic ganglia, T1 through T4. This is your thoracic vertebra that it comes out at. If you have a spinal cord sever above T12, you generally will have a loss of sympathetic tone. This is also what gives us neurogenic shock. The parasympathetic nervous system comes out pretty high. It comes out in a cranial nerve, or the 10th cranial nerve, the vagus nerve. Specifically speaking about the heart, The vagus nerve controls the rate. So the sympathetic ganglia and the sympathetic innervation controls essentially the rate and the speed, while the parasympathetic nervous system pretty much controls the brakes, or when to slow down the heart rate. So again, these things work just like a teeter-totter and oppose one another. We'll see this in a lot of examples as we continue. Sympathetic nervous system has multiple receptor sites. Receptors are alpha and beta receptors. Their chemical neurotransmitter is norepinephrine. These nerve endings are called adrenergic. So whenever we see these receptor sites, they're through various locations throughout the body. We're going to consider them as adrenergic receptor sites. The adrenergic receptor sites increases the heart rate and contractile forces of the cardiac muscle and vasoconstriction. And if we'll just remember a few little things at this point, alphas equal vessels, and betas equals muscles. Examples: an alpha-1 stimulant would increase the stimulation to the alpha-1 receptor site and cause vasoconstriction, or constriction of the vessels. An alpha-2 does just the opposite of that and kind of helps us eliminate or inhibit norepinephrine. A beta-1 works on the muscle tissue and makes the heart beat harder, faster, and stronger. A beta-2 dilates out smooth muscle. Example of this is going to be the drug albuterol. It is a beta-2 agonist, which means that it stimulates the beta-2 receptors. This would allow for smooth muscle dilation. The parasympathetic nervous system. Neurotransmitter is acetylcholine. Nerve endings are known as cholinergic. The heart rate slows, as do the atrioventricular conduction rates. Adrenergic receptors and their effect on the heart rate. Adrenergic. Sympathetic nerve fibers that use epinephrine or epinephrine-like substances as neurotransmitters. Those are all considered adrenergic receptor sites. And a receptor is a reactive site or cell surface or within that combines with molecules to produce a physiological effect. Example of this: if I had a button that when pressed would increase the rate of the heart, this is what a receptor would be. This receptor, depending on who it responded to, in this case we're considering it an adrenergic receptor, this one would respond to beta-1 stimulant. Now, not well known at this time, but whenever we enter pharmacology, you will know it quite well. Epinephrine stimulates all of the adrenergic receptors: alpha-1, alpha-2, beta-1, and beta-2. So if I put epinephrine on board, it definitely would stimulate this beta-1 receptor. It would also stimulate beta-2, alpha-1, and alpha-2 simultaneously. This is where some of our ugly side effects in epinephrine come from. Cholinergic. Parasympathetic nerve fibers that use acetylcholines as neurotransmitters. And again, we're talking about the receptor site. If the receptor site receives acetylcholine, it is considered a cholinergic receptor. Effects of alpha and beta receptors. Organs affected by alpha and beta receptors. Organs affected the heart. Is the heart affected by alphas? Yes. Are they affected by betas? Beta-1, yes. Beta-2, no. The lungs. Do they have any receptor sites on them as far as alphas go? If you'll look at this, it says no. The lungs have no beta-1, but they do have a beta-2. And the vessels themselves, beta-1, no. Beta-2, yes they do, the smooth muscle and the tunica media, but pretty much they will respond to the alpha response more than anything. So if you're wanting to decrease the lumen of your vessels or vasoconstrict someone, an alpha-1 receptor is probably going to be the best. If you want the bronchial tubes in the lungs to dilate or become bigger, then beta-2 is going to be the way to go. If you're wanting the heart to beat harder, faster, and stronger, beta-1 is going to be your receptor site. Effects of alpha and beta receptors. Alpha, vasoconstriction. In the alpha receptors, it pretty much increases blood pressure. Beta-1 increases the heart rate and increases the contractile force strength. And the beta-2 causes bronchial dilation, and the muscle inside of the tunica media gives us a little bit of vasodilation. However, if we put something like epinephrine on board, we are going to get bronchial dilation. We are going to get both of these and increase heart rate and contractile force strength. But at the point that the alpha-1 is stimulated, it is definitely going to overpower everything that we see with the vasodilation occurring. So remember A, B, C, D. Alpha constricts, beta dilates. This is the end of chapter 2. If you have any questions, you feel free to contact me. Roy Smith, phone number is 405-219-7613, or you can email me at smithr@imsa.net. Thank you.